I know you enjoyed the presentations from this morning. They were really just a show of excellence, and I appreciated the topics, and I hope you did too. Well, this afternoon, we're going to have three excellent speakers. Dr. Ferdinand, who is going to be speaking to us on advances in hypertension control and new concepts and approaches. Dr. Ferdinand is the Gerald S. Berenson Endowed Chair in Preventive Cardiology, Professor of Medicine at Tulane University, School of Medicine. Following Dr. Ferdinand, who is joining us by Zoom, we will have Dr. Pardo. Dr. Pardo is an assistant professor at Weill Cornell Medicine, medical director of the Women's Health Practice and New York Presbyterian and Ambulatory Care Network. Dr. Pardo will join us on the panels once Dr. Ferdinand is done, and then lastly, speaking on uterine myomas will be Dr. Slimy, who is co-founder and executive director and surgical director of the International Medical Response Foundation. So thank you all for joining, and we will lead right into Dr. Ferdinand.
Thank you very much. I'll try to move along quite briskly so we will have time to have a panel discussion, questions and answers. Let's go to the next slide. You moved through all of the slides. Let's go back to the beginning. All right, stop there. Okay, this is a bill, so each of these will fly in. I'm going to review the impact of uncontrolled hypertension in diverse populations. Next, I will talk about best practices for clinical care. You can click, it'll build. Next, I will update the new blood pressure goals and patient-centered approaches. And then finally, implementation of best practices. Click each of those, it'll move along. One of the things that you'll note is that cardiovascular disease has had an uptick. Some of this is due to the pandemic where people lost contact, if you can click, with their primary care clinicians. So you have a lot of risk factors that got worse, and the manifestation of that is an actual increase in mortality rates recently. Next slide. Keep clicking. Next slide. Now we know that cardiovascular disease, heart attack, strokes is primarily due to how we live, work, and play. If you look at the modifiable risk factors, however, this is from the global panelists looking across the world, the most powerful and prevalent of the risk factors is an elevation of systolic blood pressure, even more than simply BMI, LDL cholesterol, smoking, or diabetes. Next slide. The red line is the linear relationship on the x-axis, reduction in systolic blood pressure, and on the y-axis, cardiovascular events. So you see that there's a downward trend such that lower is better. Next slide. The click goes to the SPRINT trial, which was a major NIH trial, over 9,000 patients, and it led to the 2017 high blood pressure guideline that suggested that the goal is now less than 130 over 80. It's no longer 140 over 90. And that's because in SPRINT, they targeted a systolic blood pressure of 120 and showed getting a more intensive blood pressure reduction decreases heart attack, strokes, cardiovascular mortality, and overall mortality. Click one more time. There have been a series of recent studies, STEP, ESPRIT, and BP Road, done out of China, that continue to show that regardless of whether a person has diabetes, whether they're high risk, whether they're even over the age of 75, decreasing blood pressure intensively lowers cardiovascular events. Next slide. These colored populations are the various populations in the United States, and I use this slide to depict several things. One is, click, you see that awareness and treatment are actually fairly high, so it's no longer just enough for us to do blood pressure screenings. Where we fall down, click again, please. is in control across all the various populations. And if you look at the population that's defined as non-Hispanic Black, it has the worst levels of control. So people know they have high blood pressure, they often are getting treatment, but it's where we have control as the problem. Next slide. Next slide. The top dotted lines are heart failure mortality. Now, I use mortality because it's something that's not debatable. This is not social science. And if you look across the x-axis, for decades, the top dotted line, click again, non-Hispanic Black or African Americans have the highest rates of heart failure-related mortalities. And this is primarily driven by poor control of blood pressure. Heart failure is one of the leading causes of admission in the Medicare population. In the younger population, it starts related to a poor control of hypertension. Next slide, click. And you see the highest rates, the top dotted line, Black or African American. And this has been going on for decades. Next slide. Another problem that we see as a target organ for uncontrolled hypertension is end-stage renal disease. That's the non-Hispanic Black or African American, only 13 to 14%, but almost a third of patients who are on end-stage renal disease dialysis are Black. And that's because of the disparate rates of blood pressure control. Next slide. There's a new risk calculator, you're going to hear more about this, in which we take various things, click, sex, age, blood pressure, kidney function, cholesterol levels, and we get an assessment of a person's risk. At around 11 o'clock on the dial, you see SDOH, that's the social determinants of health, where people work, live, play, and pray. The new risk calculator is going to request that we put in the zip code because we know that the zip code is a powerful predictor of risk along with the other conventional risk factors. Next slide. And if we look at the various populations across the United States, uninsured status leads to poor blood pressure control and bad outcomes. And it varies across the various subpopulations. One of the problems that we're going to have is that if we restrict Medicaid—
Recording in progress.
And we restrict the Affordable Care Act, you're going to have more patients who have uncontrolled hypertension, and they're going to have worse outcomes. Next slide. This concept of the social determinants of health is not just a term of art. It has a real impact. On the left-hand side, you see the hospital. This is where people go to get care. This particular concept of the revolving door is from a paper that I was part of the working group. And what we suggested is patients leave the hospital, then they go into adverse social determinants of health, financial hardship, high co-pays, food deserts and food swamps, disadvantaged residential environment, and then return back to the hospital. So you can see that simply treating patients in the emergency department or even in the clinic is not going to be adequate if we don't address these social determinants. And I think having an uninsured patient is a cocktail for disaster. Next slide. The last guideline in the United States is actually from 2017. We may have new guidelines in the future, but the last guideline from the American College of Cardiology, American Heart Association, and multi-societies is where we have the present recommendations on treating blood pressure. Next slide. That is where the definition came that hypertension now starts at 130/80. The idea is not to give patients diseases that they don't have. But if you can remember that regression line, lower is better. And based on the SPRINT trial, and now even on some trials coming out of China, intensively lowering blood pressure with a goal of 120 is better than waiting for 140/90. In fact, if we wait for 140/90, it's now defined as stage 2 hypertension with an increased risk for heart attacks and strokes. Next slide. Next slide. This is the algorithm from the guideline, and in the interest of time, I'm not going to go into great detail. I just put a red box around stage 2 hypertension. What we used to call the start of hypertension 140/90 is now considered stage 2. And what the red box says is along with lifestyle, non-pharmacologic therapy, these patients will need blood pressure medications. Medications are not bad. Medications are good when used appropriately. Next slide. Next slide. Next slide. Which drugs to use? Well, there are over 125 antihypertensive agents, but the ones that appear now to be most effective are at the top: the thiazide type diuretic, and if the patient has kidney disease, loop diuretics, furosemide, torsemide. The long-acting calcium channel blockers, not short-acting, but long-acting. I preferably like amlodipine. It tends to have a really long half-life. Even if the patient misses a dose, it remains effective. And then the combination of either an ACE inhibitor, such as lisinopril, or an angiotensin receptor blocker, such as losartan, olmesartan. Next slide. So these cocktails of medications, often giving 2 medicines in 1 pill, is going to be needed for many of these high-risk patients. Next slide. And in some patients, they're going to need 2 or more medications. The colored bars are some of the outcome study in which we look at how to decrease heart attack, strokes, and kidney disease. The names of the studies are not as important as what the red line shows. In these large outcomes trials, in order to protect against some of the ravages of hypertension, it's not 1 or 2. It's often 2, 3, or even 4 medications. So what we ask our patients to do is understand that the trials have been done. I don't want my patients to be in a placebo trial. The trials have been shown that 2 or even 3 medications in these high-risk patients will be needed to prevent the ravages of heart failure, heart attack, strokes, and end-stage renal disease. Next slide. This is directly from the 2017 high blood pressure guideline. As I mentioned, we're going to have new guidelines perhaps in the near future. But what they suggest is for these patients who have high blood pressure, it's going to be 2 or more antihypertensive medicines to achieve a target now of less than 1/3/80. This is for most adults, but it's especially true in Black adults who often have more severe and difficult to treat hypertension. Next slide. Now, there is a term of art also called resistant hypertension. These are patients whose blood pressure remains greater than 1/3/80 despite being on 3 or more medicines at optimally tolerated doses. And this particular algorithm from the American Heart Association suggests how we should approach these patients who have resistant hypertension. Next slide. First of all, you want to make sure that they're getting an exclusion of secondary causes. These are things that may be causing their hypertension, such as pheochromocytoma, aldosteronism, renal artery stenosis. And you want to make sure that the patient is adhering. Next slide. Regardless of whether or not the patient has resistant hypertension, you also want to maximize what we call therapeutic lifestyle interventions. That means that you want to ensure the patient's getting adequate sleep, that their dietary pattern does not include excessive sodium, an increase in potassium, which would mainly be the DASH type diet, appropriate weight loss, and physical activity. Next slide. And then finally, you're going to optimize those 3 drugs that I mentioned earlier. And that includes a RAS blocker, that's an angiotensin converting enzyme inhibitor, or an ARB, calcium channel blocker, and diuretic. Next slide. In some patients, they're going to even need more medications, but perhaps those 3, if used appropriately, will control the majority of people, even with resistant hypertension. Next slide. There's also in medicine a move now in those difficult to treat patients to consider another thiazide type diuretic. It's not hydrochlorothiazide, but chlorothalidone or indapamide, which may be more effective in patients with moderate kidney disease. Next slide. And in the very difficult to treat patients, we need to block the aldosterone effect, either with spironolactone or especially in middle-aged men who want to avoid erectile dysfunction or gynecomastia, Preventative. Preventative is similar to spironolactone, but doesn't have those estrogen stimulation off-target effects. Next slide. When we look at populations, this is from the Regards trial in the Jackson Heart Study. Jackson, Mississippi, the Regards is in the South. And you look at patients who have treatment-resistant hypertension. The reality, next slide, is that most of them don't have ideal lifestyle. Next slide. Very few are using chlorthalidone or indapamide. Next slide. And less than 10% are using either spironolactone or eplerenone. So we should identify these patients who have poor control of blood pressure, address lifestyle, and use appropriate medications. And in many cases, that includes an aldosterone antagonist. Next slide. I mentioned several times the SPRINT trial. It was published in New England Journal of Medicine in 2015. It was a landmark trial, over 9,000 patients. Next slide. And what they showed in the SPRINT trial, the Kaplan-Meier survival curves separate. Intensive treatment in the orange decreases a composite of myocardial infarction, acute coronary syndrome, stroke, heart effect, heart failure, and death from cardiovascular diseases. Next slide. And one thing in the SPRINT trial, most people don't recognize this, is that the mortality benefit with intensive blood pressure reduction was shown. So death from any cause, again, the Kaplan-Meier survival curves separate. Intensive blood pressure treatment saves lives. Next slide. This is called a forest plot because it's like a tree limb. And you look at all the various subgroups in this large landmark trial. Next slide. You can see that to the left, intensive is better, whether the person's over 75. So this idea that aging is a natural process and blood pressure should be part of it, no, that's not true. We treat these patients intensively with care, of course. Next slide. We also treat them if they are male or female. Next slide. And even if the blood pressure is just a
Recording in progress.
We lost projecting the slides. She's going to go back to it. So I think the take home thus far is that blood pressure is the most powerful and prevalent of the cardiovascular risk factors, that intensive blood pressure saves lives, it reduces heart attacks, strokes, heart failure, and that it has a wide effect across a wide range of patients. Next slide. I mentioned the Chinese studies. This one is a treatment of hypertension in older patients, published in the New England Journal of Medicine. Next slide. And similar to the SPRINT trial, it showed that in older patients, targeting blood pressures of 110 to 130 had a lower incidence of cardiovascular disease than the conventional means of treatment. Next slide. So regardless whether or not a person is 75 years of age, with care and caution, we should intensively lower blood pressure. Next slide. This is the results out of that large Chinese trial. You can see standard versus intensive. The total number is 9,000 patients, and they lowered blood pressures well under 130 millimeters of mercury. The 140/90 is important, but it's not enough. The standard treatment did not have the same benefit as more intensive treatment. Next slide. Next slide. This Kaplan-Meier survival curve you see separates, similar to what we saw in SPRINT, but remember these are in patients who are 75 years and older. The p-value is 0.007. So lowering blood pressure is important regardless of age. Next slide. Next slide. Here's another recent trial out of China. Again, they have these huge trials that they can do in China. This was just published last year. And it looked at lowering the blood pressure to a goal of even less than 120 versus 140, with or without diabetes. It's called the ESPRIT trial. Next slide. And it's going to show the same result, intensive blood pressure reduction, whether or not the patient has diabetes or previous stroke, targeting less than 120, reduces major vascular events, and there was only a minor excess risk. Next slide. Next slide. Here again, at the blood pressure, you can see how robustly they lowered the blood pressure. Let's keep going. Keep going. And a similar forest plot to the left, intensive being better. Next slide. Major cardiovascular events. Next slide. Death from any cause, and the primary outcome of combining cardiovascular events and death from any cause. Next slide. And a final recent trial published in November out of China looked specifically at patients with type 2 diabetes. At one point, we thought maybe there's not as much data on persons with diabetes, but this trial showed, again, huge, next slide, huge population, that intensively lowering blood pressure targeting 120 versus the conventional 140 had a decrease in major cardiovascular events, with the lower intensive treatment being better than the traditional systolic of less than 140. Next slide. You can keep going. Keep going. Here again are the blood pressures, and you can see the type of blood pressures that were achieved. Next slide. Huge population. Next slide. This is a new concept that I think all of us should be aware. Many times with older patients, we'll say they have Alzheimer's, and to a large extent, it becomes a wastebasket diagnosis. A lot of these patients actually have the ravages of poorly controlled hypertension and microvascular disease. And in fact, if you look at dementia, memory, and cognitive dysfunction, hypertension is a primary risk factor for small vessel ischemic disease with white matter abnormalities. Those of you who are clinicians, or if you have family members who are said to have Alzheimer's or dementia from aging, many times what it is the ravages of blood pressure. Better blood pressure control may actually reduce Alzheimer's disease and related dementias, and there's a strong association when you start lowering blood pressure appropriately that you can help cognitive function. Next slide. So hypertension is a primary risk factor for this small vessel ischemic disease. Next slide. It's predictive of cognitive decline and dementia. Next slide. Better control of blood pressure has a profound effect in preventing dementia. Next slide. And we have strong data to support that getting a goal of less than 130 is recommended for mild cognitive impairment and dementia. I think this is a powerful message for patients who not only want to affect the avoidance of heart attacks and strokes, but the loss of memory, loss of the ability to live independently. Next slide. Let me make a few comments on the 15-minute visits. Those of us who work in clinical care are often put in a box, 99214, where you're supposed to see patients, often complicated patients, in 15 minutes. And it's really hard to address the social determinants of health, since this has at least an 80% impact on patients' disease states. Next slide. I recommend, and this is from the guidelines, that we consider out-of-office blood pressure, where patients are given a valid cuff, or if their insurance can cover it, to confirm the diagnosis and titrate, often in combination with telehealth. In the 2017 guideline, it's a 1A evidence. Next slide. Out-of-office of blood pressure will remove the white coat hypertension effect, where about 20% of patients, and we used to think that they were wrong, but we now know they're right, 20% of patients will have elevated blood pressure with the anxiety of stress in the clinic environment. Next slide. Next slide. Next slide. Another approach that I think is beneficial is going into the community itself. In New Orleans, for several decades, we've had the Healthy Heart Community Prevention Project. It's a 501c3. We had an NIH grant many decades ago, and we continue to go into the churches and community centers to educate and empower patients about their cardiovascular risk factors. Next slide. And we now suggest that patients, if they can afford it or if their insurance can cover it, go to validatebp.org and get a blood pressure cuff which is validated and that the measurements we know are going to be true. Next slide. Next slide. We did a small pilot in New Orleans called Text My BP NOLA, and it was from Healthy Heart along with LA CATS, which is a consortium of all the various organizations in Tulane University. Next slide. And what we did was give the patients a blood pressure cuff. This was a grant, small pilot. And in Text My BP meds, we noticed an increase in medication adherence with text messaging and social support. Next slide. Starting at a blood pressure of about 142, we lowered it to about 131 plus or minus. P-value reached statistical significance. And these were real patients, 6 to 8% female, middle age and older, 90% Black. Next slide. And what it suggests to me is that empowering patients, educating patients will have a profound effect on blood pressure control. It's not enough just to go 2 to 3 times a year for the magic 15-minute visit. Next slide. The American Heart Association has a wonderful paper on implementation strategies for blood pressure control. This working group was chaired by Marwa Abdullah from Columbia. And what it suggests is that if you look at how to control blood pressure, next slide, going around the clock, there's several steps which may be key in controlling blood pressure. Let's start at 12 noon and move around the clock. Measure the blood pressure accurately. For the most powerful and conventional blood pressure risk, we don't do a good job in the clinic. Next slide. Use team-based care. The different colors, it's not just about the doctor. It includes nurse practitioners, physician associates, pharmacists, medical assistants, the patient and the patient's family. Next slide. The next cartoon, next slide, shows exercise equipment, but you really don't need exercise equipment. Physical activity helps with blood pressure control. Next slide. Standardized treatment protocol, helping clinicians to make sure that they're using the cocktail of medicines that's often needed and improving adherence with quality improvement. Keep clicking. Financial levels, keep clicking. And although President of the United States, we want to say that this doesn't exist, we know indeed it does. Some of the structural inequities, trying to dismantle those barriers to care that our patients often face. Next slide. I mentioned the 15-minute visit. The electronic health record is an important way to document care, but we as clinicians often spend more time treating the computer and the patient feels like a bystander. Next slide. So what I would suggest is that you know the evidence, we know the guidelines, we know the medications, we use lifestyle modification. What's most important, and this patient allows me to use this picture, is that we sit down, eye level, culturally competent, clinically appropriate language, talk to people. Next slide. Limit the amount of information. Don't overwhelm patients with our Latin-based language. Slow down. Avoid medical jargon. Use pictures and models and what we call the show me technique. After you finish, ask the patient any questions. What did I just say? Tell me what I just said. Because the patient who's empowered is going to be living with antihypertensive medications, living with the ravages of hypertension. And in order to avoid end-stage renal disease, heart failure, strokes, and even dementia, we need empowered patients. Next slide. Here are a few keys to controlling blood pressure. I'm not going to go in great detail, again, in the interest of time. Let's move along quickly. Have an agreement with the patient on your blood pressure target. Use combinations. Remember chlorothalidine, dopamine, long-acting angiotensin inhibitors, and calcium channel blockers. 90-day refills if you can. Telehealth is a powerful tool, connecting patients along with their care. Screen and address the social determinants of health. And number 10, the team. It's not about the doctor. It's a group of people, including the patients and the significant others, that are going to help to control blood pressure. Next slide. My final slide, the cartoon is from the CDC, and I have to check to make sure it's still up on the site. It shows the little lady with the boxes so that she can help reach the apples. People who are disadvantaged need help. The words are mine. Next slide. And what I suggest is that we need targeted interventions, next slide, to identify and eliminate disparities. These disparities are real, based on race, ethnicity, sex, gender, geography, socioeconomic status, ability, or disability. Healthcare equity, then, is not social science. It's a moral and practical impairment. Next slide. Thank you. Here are my contacts, and I try to stay on time till we have time for discussion.